Well, thank you very much. I certainly agree with the testimonial of that Florida resident when he said that President Obama is not perfect. I don't know if he said anything else. That's the only part that I actually heard. Well, thank you again for coming here. We've got a great panel, and this panel somewhat mirrors something that we did in the Florida House in our Healthcare Workforce Innovation Committee, and some of the members that are here were present at that panel, where we had a real open discussion about some of the challenges to meeting the demands for workforce in Florida, and some of the possible solutions for that. So, without further ado, the way that we're going to set this up today is that I'll make a small introduction. Each of our panel members will speak for 5 minutes and kind of talk about, in their specific areas, how they feel that we can improve workforce access and affordability. And then we'll have a light discussion and, of course, take questions from the audience. Coming up next is Dr. George Valdes. He's a doctor of nurse practice and also a CRNA. This is a very unique area, doctor, because there's quite a debate in regards to anesthesiologists and certified nurse anesthetists. So next we'll hear from Dr. Valdes on how we can expand affordability and access through certified nurse anesthetists. Dr. Valdes.
Thank you, Chairman Oliva. Like Chairman Oliva said, I'm a nurse anesthetist. I am an advanced nurse practitioner in anesthesia. I have a doctorate degree in nursing practice, which is very similar to JD, who is a doctorate degree in the practice of law, and a PharmD, who has a doctorate degree in pharmacology. My message is quite simple. The laws for delivery of healthcare models within the state of Florida are antiquated. They were written 30 years ago and have not kept up with the time. And because of this, the restrictions that are being placed on advanced practice nurses are creating unnecessary loopholes. They're costing the state a lot of money. Let me tell you how I really practice. So in the state of Florida, I work under two different models here. I work under medical direction, and I work under non-medical direction. I still have to have a physician supervise me. So when I work under medical direction, I work at a hospital. That anesthesiologist is supervising 2 or up to 4 nurse anesthetists. And they have to come in at certain times of the procedure. Make no mistake though, I am in the surgery the whole entire time. The anesthesiologist may come in at the beginning and may never come in again, or at the beginning and just at the end. I stay with the patient the entire time. When I'm working in an outpatient surgery center, such as a GI center or a plastic surgery center, I am non-medically directed. And so who signs my protocols for the state is then the gastroenterologist or the plastic surgeon. In that instance, the anesthetic is deferred to me. Outcomes, the same. Actually, there are 16 states who have removed supervision of nurse anesthetists. And there are a multitude of peer-reviewed studies that all say the same thing. There are no outcomes. There are no difference in outcomes in safety, regardless of who is at the head of the bed, anesthesiologist or a nurse anesthetist. Whether they're working together or with non-supervision, there are no differences. In fact, there are many scenarios within the United States where CRNAs commonly serve as the sole provider of anesthesia, as is the case within our military. So let's come back to Florida then. So we require physician supervision. True, okay. But however, there is no doubt that by eliminating this illusionary supervision required by anesthesiologists, the anesthesiologists are pretty much the most compensated healthcare specialist within the healthcare arena. If you remove that supervision, the cost will come down. So what I like to call is, what are these hidden costs of supervision? Very simple. Yesterday, there was a small little study in a facility here in Orlando, a Deloitte initiative to basically monitor how long are the start times for anesthesia cases. Well, if that anesthesiologist has to be at the beginning of all 4 cases to induce anesthesia, there is a delay. That delay was averaged at about 20 minutes. So this is costing surgical time. Surgical time on average is about $60 a minute. Times 20 minutes. Times 60 surgical procedures that were done in this hospital. That's almost $100,000 that we could have saved yesterday. So that could have been another removal of a gallbladder. It could have been a replacement of a hip joint. And where does all this money come from? It's passed down to the consumer and to patients. Another hidden cost is subsidies that the hospitals pay the anesthesia groups to maintain these salaries. And these subsidies range anywhere from $120 up to $180, on average $140,000 to $150,000 per anesthesia location. Again, where does the hospital get this money? It's passed down to insurance companies. How do they pay for this? Passed down to the consumers. Right there, we have cost savings while still delivering the same quality care. Increasing primary care consultations will lead to an increased need in surgeries. Who is going to be around? There will be a problem with access. So by anesthesiologists and nurse anesthetists working side by side, all hands on deck, each one of them doing their job in anesthesia, manning their own rooms, you are meeting this workforce demand and doing it at a cost-effective manner while not duplicating services.
Thank you, Dr. Valdes, and certainly have some additional questions in regards to some of the comments that you made and some of the things we heard during our committee when you had a chance to testify there. You know, if we had a panel made up of a lieutenant colonel from the Army, an emergency room physician, and a legislator who's a vice chairman of a healthcare committee, that would make a pretty good panel. We have the ability to have that wrapped up all in one person. And I'm very excited to hear his perspective on all of this because of all the areas that he's seen it from. So it's with great pleasure that I introduce Dr. Lieutenant Colonel Vice Chairman Pigman.
Thank you, Mr. Chair, and thank you for those kind words. But in a point of honesty to the audience, I'm just a country doctor, and I'm a boots-on-ground kind of guy. And my message is this: shame on us. Shame on us. Florida has been a leader in innovation in agriculture, in business, and in education. And we've seen fantastic gains in each category. And in fact, we have a tradition of continuing that innovation. We don't rest on last year's gains, we work to improve beyond that. But in healthcare, for whatever reason, in healthcare, we lag. We don't just lag. When it comes to how we deal with our advanced practice nurses and our certified registered nurse anesthetists, we rank 50th of the 50 states. How could that be? In a state that's so proud of its education, so proud of its agriculture, so proud of its business, so proud of its tourist industry, we could let that important industry languish. You've heard important testimony from these very three smart people telling you about the hindrances they face. Well, here's what drives me. We are blessed with an aging population. If we all died at 50, this wouldn't be a problem. I wouldn't be here. But we're blessed with a longer lifespan. It's an aging population. It's a fantastic problem for society to have. At the same time, we're dealing with a healthcare workforce that isn't keeping pace with the needs of the future. It's just not primary care, although that's perhaps where the lag is greatest. We're not producing primary care physicians. We're producing a very small number. The amount we have today compared to the population will be the best we will have it. We will look back to this year, 2014, and say that was a good day. We had fantastic staffing in 2014. We're simply not going to produce enough family practitioners in general practice internal medicine to meet the primary care need. But it's all physicians, all specialties. all of our healthcare needs, as we currently have things arranged, will not have sufficient manpower to provide that care. So that's a demographic reality. You can't ignore it. Now, the second thing that drives me is safety. We've heard a lot of prejudicial talk, comparing one group to the other, alleging unsafe practice in some and safe practice in others. I will tell you that after a careful review of the literature, the data that's published, there is no difference in safety. There is no difference in death. There is no difference in complication. The advanced practice nurse does as good a job taking care of chronic medical illnesses as a family practitioner. Now, it may be that the advanced practice nurse spends more time with the patient. There may actually be additional benefit. With regard to anesthesiologists, physicians, and certified registered nurse anesthetists, there is no difference in the data. These are huge studies of over 2 million cases that were case controlled. These were the same patients statistically. More importantly, those studies were looking for a difference, and they failed to find a difference despite 2 million cases studied. There is no difference. Additionally, we'll pick on Dr. Valdes over there. Anesthesiology is a pretty technique-intense field. Now, I'm a reductionist. All those boys ever do is put tubes in things. Whether it's a needle in a vein, a needle in an artery, a needle in the chest, a needle in the throat, a tube in the throat, tube in the stomach, tube in the bladder. And in that circumstance, it's who does it the most. And I would submit to you, it's the CRNA who's located in one room all day long, seeing case after case, who probably has the better skill set. But we're not here today to talk about better. We're here today to talk about equal, that safety is equal. Now, there's a lot of prejudicial talk, but there's no data that supports it. And at some point, we, Florida, need to move beyond the jingos, the headline phrases, the boogeyman scaremongers, and do decisions based on data. And the data shows safety. If there's a recent study that shows otherwise, please bring it to me. I will look at it critically. And the final point, Mr. Chair, thank you. I've spent a fair amount of my time with the military. Initially Navy, with the Marine Corps, now Army. I saw the light. No, I apologize to the folks in the Marine Corps. But my point is this. In those deployed circumstances, we all worked side by side. Yes, there was a commanding officer. Commanding officer wasn't a physician. It was an administrator, just like the administrator of the hospital is an administrator. But we worked collegially. And in fact, most of the patients in the clinic, with their cough, with their runny nose, you go, oh, that's a cold. Well, it might have been Q fever. Who knows what might be coming up from the dust in Iraq. Those are advanced practice nurses. And I'll tell you what, when I showed up in Mosul, I didn't know very much about Q fever, Coxiella burnetii, but we learned together. The fact that I've been a physician for 30 years, there's still stuff to learn. There's no guarantee that I know anything. And when we had a blast trauma case come in, it was the CRNA who was looking for vascular access above where the blast trauma was. It was those people putting in the central lines. It was a CRNA who intubated. Now, there was an anesthesiologist there, but the hands on the patients were the young CRNAs. And I think we see this on the civilian side with military hospitals and Veterans Administration hospitals. They recognize the absence of any safety concern. They recognize the wonderful contribution each category of provider can provide, and they're in the forefront of removing hindrances that prevent each category from working fully. So, Mr. Chair, I apologize, But once again, I emphasize, shame on us. We can do so much better.
Thank you so much, Dr. Pigman. Thank you. Yes.
They must be Chair Hudson's people.
It really is a rare opportunity when we get a chance to have a policymaker that has such a very direct experience in the area. And we have to take special advantage of that during our time in the legislature and make sure that the policies that we pursue are those that are most in line with reality. So let's start our questions with a couple very specific areas. So we've heard some generalities about each of these different areas. We've heard a lot about the overarching type of savings and whatnot that we could have. But let's get to some very direct, boots-on-the-ground type realities. And I'm going to start with Dr. Valdes, because there's been a lot of talk about specialties and in particular CRNAs. So the idea is that an anesthesiologist needs to supervise your activity, because while during a routine procedure, you're perfectly suited to handle it, in the event of an emergency, what is being referred to as the rescue rate, in the event that a rescue is necessary, you may not be entirely appropriate to save that patient. Now, Dr. Pigman has talked extensively just recently about the fact that the procedures are mostly being done, intubations of all sorts are being done by nurse anesthetists. But I want to, just for a point of clarity, so in a hospital situation, you would most likely be supervised by an anesthesiologist. The protocol says that you must be supervised by a physician. So an anesthesiologist would be there in the event that there would be an emergency. But let's say that I'm having an endoscopy, or that I'm having laparoscopic knee surgery, and I'm in an outpatient center. Typically, there is a nurse anesthetist and there's a physician. Is there also typically an anesthesiologist in that scenario?
No, there's not.
So in the event of a surgical procedure that is either cosmetic surgery, laparoscopic, or an endoscopy, and a situation does happen that requires a rescue, who's in place to do the rescue?
That would be the nurse anesthetist.
And this is going on in Florida throughout the state
This
today.
is going on in Florida throughout the state, yes. In Florida, and I'm very glad for the question, actually, because in Florida, CRNAs can work basically non-medically directed. I work non-medically directed. I work in a lot of plastic surgery centers, and I work also in a GI clinic. Whenever there is an emergency situation, I am there to respond. And in lieu of my training, it is well within my scope to do so. Because of my background, I am educated in pharmacology and physics and chemistry. I am taught how to take patients from a healthy state and put them under anesthesia, which is what we so call an unhealthy state, and bring them back. This is what I do every day. So doing this in an outpatient surgery center is not any different than doing it in an OR. And in an OR, you're absolutely, and I mean OR operating room, you're absolutely correct in the assumption, yes, there is an anesthesiologist who is supervising, but that anesthesiologist may be supervising 4 other rooms. The anesthesiologist may be in an OB floor. And so if there is a rescue, I am the one who is doing that rescue. By the time that anesthesiologist goes to the GI center at a hospital, let's say that they are doing a procedure and the patient emergently needs to be intubated. By the time they get to me, more than likely, the patient will be intubated already and stabilized, because this is what we do.
So in the event of a laparoscopic surgery and endoscopy, who is your supervising physician?
In the event in a hospital,
currently under Florida statutes right now, who supervises you in these scenarios?
A physician.
When you say a physician, is it an anesthesiologist, somebody that understands your area of medicine?
In a hospital, it is an anesthesiologist. For the most part, there are certain hospitals where it may be a physician because there is no anesthesiologist. That is why I'm saying a physician. The common practice within the state of Florida is a anesthesia care team model where there is a anesthesiologist and nurse anesthetist, but that is not in every hospital in the state of Florida.
So for cosmetic surgery or laparoscopic surgery, would the supervising physician be an orthopedic surgeon?
It may be, yes.
So they can currently sign off?
They will sign off on my protocols, yes.
And
They delegate the anesthetic to me.
And you are fully in charge of that anesthetic?
I am fully in charge of that anesthetic, yes.
That's an interesting point, because I think that a lot of the concern is that some of what is being proposed would unleash nurse anesthetists throughout the state, and that they would be performing now outside of a supervision. But it seems to me like you're already performing outside of that supervision, and we're basically just keeping that protocol. What would you say is the value of having an orthopedic surgeon sign off on your work as a nurse anesthetist?
The value is you are not duplicating anesthesia services, and you are basically reducing cost overall. The cost of there is a cost attached to supervision. So the doctor that is performing orthoscopic or laparoscopic surgery or an endoscopy, he actually gets part of the revenue that comes from anesthesia? No, he does not. If it's an anesthesiologist, they do. If it is a physician who is not an anesthesiologist, they cannot bill for anesthesia services. Anesthesiologist bills for anesthesia services.
So that would probably explain why a lot of procedures are moving outside of the hospital and outside of that scenario to reduce the cost of anesthesia.
This would be correct.
Well, that's important to look at, because that's a real-world scenario of what's actually taking place day to day in the real world, and it's happening right now. And so when we talk about patient safety and the possibility for patient risk, we have to first fully understand what is currently going on. So with that segue...